What if I told you that until just a few years ago, one of the most commonly used tools in obstetrics built race directly into its formula, shaping how patients were counseled after childbirth after a previous C-section? I'm Dr. Michael H. Ford, and this is a story you need to hear. For years, hospitals across the United States used something called the VBAC calculator. It was originally created to estimate the likelihood that a patient could safely deliver vaginally after a prior cesarean. Those numbers didn't make the final decision, but they often guided how providers framed the risks, the options, and the birth plan. But here's the part most people were never told. Until 2021, the original version of the calculator included race and ethnicity as variables. Selecting African American or Hispanic changed the predicted probability, not because of biology, but because older data sets showed lower VBAC success rates among these groups. Now that raised an uncomfortable question: were we measuring risk or were we reinforcing it? Experts in maternal health, public health, and medical ethics pushed back. Race is a social construct, not a biological category, and using it inside clinical algorithm risk embedding inequities into the very tools meant to guide care. At the same time, no evidence showed that the calculator alone determined outcomes for every patient, or that removing race would fix long-standing disparities shaped by hospital practices, access, and structural racism. The reality was more complex. In 2021, ACOG and the Society for Maternal Fetal Medicine released a revised race-free calculator. Studies later confirmed it remained similarly accurate, proving that race was never medically necessary to begin with. Removing race didn't solve everything, but it marked a shift, a recognition that when clinical tools influence real conversations and real decisions, equity must be part of the foundation. Healing starts with knowing. Follow for more.